Okay, on this call, what we're going to is a difficulty breather call. It's a 73-year-old male. History of COPD according to the dispatch information, and the patient has been having problems breathing on and off for a few days, and actually there was an ambulance at the scene about a day and a half ago, and the patient refused to go to the hospital at that time. So we're going to this call. I have not been here before, so I'm not sure what happened when he refused medical assistance the other day, but COPD patients, some things that we should be thinking about, of course, are nebulizer treatments, possibly mag sulfate, maybe salumedrol, and even thinking out of the box a little bit about things like CPAP. Depending upon your protocols, your options, medical control, standing orders, and what you can request, or maybe even run by the doc the type of medications or even treatment like CPAP you might want to go ahead and consider. So start thinking about all that information. Of course, the more extreme ends too, as far as even intubation. So we're going to be there in a couple of minutes. Let you know what we found and give you some feedback. Out, the patient actually had some shortness of breath about 2 days ago. Called 911. The ambulance got there, and he felt better when they got there, so he refused to go to the hospital. Not quite sure how he presented to the ambulance crew when they got there, um, but I think possibly, in my opinion, if they took a little bit of a better history, they might have been more aggressive in their attempts to convince him to go to the hospital. Now, it turns out this gentleman, we didn't actually have to uh, do any medications on this patient. He actually had the same symptoms and complaints when we got there, and same thing as the previous call, where he complained of shortness of breath, more on exertion, kind of coming and going, and more at nighttime, and he felt he wanted to go to the hospital to get checked out for it. Now, when we got there, he wasn't having any obvious respiratory distress. His lung sounds were clear, and he was actually satting on the SpO2 at 96% on his nasal cannula, which was at 4 liters per minute, his home nasal cannula. This is through the compressed air type device that he had. Now, patients like this, you have to consider, yes, they've got COPD, but what other type of issues might be going on with the patient? This gentleman had a history of AFib, a history of hypertension, still smoking, despite the COPD and despite the need for oxygen all the time. So you have to think of other things that might be going on with this patient, and it might not just be a clear-cut COPD type patient where you're going to give albuterol treatments and COMB treatments, or maybe salumedrol, things like that. So treatment for this patient is pretty straightforward, and also got some follow-up information for you as well. But let's just really quickly just talk about treatment. Now, history, to me, it's part of the treatment, and part of your goal is to kind of get an ongoing history from the patient. Now, in this case, talking to the patient, he's urinating more at night, has some mild pedal edema going on, and again, having to sleep. He says having some difficulty sleeping, having to get up frequently in the night to urinate. He seems to be getting short of breath more when he's laying flat. Shortens of breath more when he's doing any type of activity, which includes even just simply walking short distances inside of his home. So treatment for him, again, since he wasn't having any active issues going on, O2 saturation was good. He was pink, no cyanosis, anything like that. Lung sounds again were clear. We did an EKG on him, just to monitor him on the monitor. Started an IV, pretty much critical care for the patient. Of course, airway management, is important. You want to, keep an eye out for this type of patient to make sure that the difficulty breathing doesn't start to, re-emerge during transport, and then you're going to have an issue on your hands. So just, of course, continue to manage the patient. Medications, we did not give any medications for this patient because, again, he wasn't presenting with anything, and didn't really see a need for any medication administration for the patient. So it's pretty much just a monitor and transport of the patient. Um, we did put him on our own nasal cannula treatment, and that actually wound up getting his O2 saturation up to the 97, 98% range by the time we got to the hospital. And the outcome for the patient was pretty much unremarkable. We got to the hospital without any type of issues going on. And actually, when we followed up with this patient, it turned out that we had something that was beyond just COPD. He was actually admitted for CHF issues. So, the bigger takeaway for me, because this is pretty clear cut, you just kind of monitor and transport the patient, and the history is more the bigger uh, information and the bigger takeaway that you need to get for patients like this to kind of narrow down what might actually be going on with this patient, beyond just the kind of tunnel vision of getting the COPD, because that's the cold type and that's the patient's primary, let's say, issue. But, was RMA the best option for this patient when he called 2 days ago? Maybe a more thorough history taking, maybe more questions, maybe directed more towards other issues that are going on, or what you might think is going on, other than just zeroing in on a COPD issue, or zeroing in on the fact that he was no longer short of breath upon your arrival. So was RMA the best option for this patient? Sometimes we can't always control what's going on with the patient. What if the patient is having other issues? What if the patient is having CHF or another issue going on that we can't actually identify because they're not having any active complaints or any active clinical presentation upon your arrival. So trying to control that what if is taking a good history and figuring out maybe what else might be going on with the patient. In the end, of course, we do have to respect the patient's wishes. So even though RMA might not have been the best option 2 days prior, we do have to respect the patient wishes. And, part of that is taking that history and being aggressive and trying to talk the patient into going to the hospital. But in the end, again, we have to respect the patient's wishes. So at that point, documentation is important for these patients because you don't know what might happen after you leave. The patient might flash over, he might be fine the rest of the day, and then in the middle of the night wind up having a acute CHF episode. So, while we do want to respect the patient wishes, we do also want to make sure that when we do an RMA for elderly patients that have extensive histories such as AFib and hypertension and COPD, and they're a long-time smoker and a continued smoker and things like that, is that you do want to make sure you document as best as you can as what you feel is going on, and try to document that you did aggressively try to get the patient to go to the hospital, but you are respecting their wishes. And in my opinion, patients like this, if you do wind up having to RMA the patient, it's always a good idea to make sure that somebody's there with the patient, a family member or neighbors, friends, or at least get an idea that somebody that the patient knows and is close to will at least be following up with the patient later on that day and checking in on them to make sure that they are okay and that their shortness of breath isn't re-emerging and they're unable to call 911 or even get to a phone because of the difficulty breathing. So to me, that's the bigger takeaway here. Again, the clinical presentation wasn't anything acute, wasn't anything that we need to treat aggressively, but maybe the bigger takeaway for me was to kind of understand that RMA might not have been the best option, try to control what might be going on with the patient by getting a better patient history and medication history and things like that. And of course, in the end, if you have to respect the patient wishes, to make sure you document appropriately, to make sure that you're covering yourself and that the patient understands the repercussions and the end result of what might happen by them refusing the transportation to the hospital, especially with a long type of a history. So that, to me, is the bigger takeaway from this response. So that's it for this first response medic. Of course, if you have a response that you did or a call that you want to discuss, be sure to go ahead and comment below in the comments or send me an email to jhoffman@ems-safety.com.